here. Okay, there we go. Um, and yeah, you can view the talk afterwards as well. So we're excited to have this great talk with Dr. Jim Denstedt, who is a current PGY4 resident in ophthalmology at the University of Ottawa, where he actually serves as chief resident. He loves to support the education of fellow medical trainees and is here today to give his talk on his experience in Baffin Island. Without further ado, I'll just pass it on to Dr. Denstedt.
Thank you, Hamza. Welcome, everyone. So as Hamza mentioned, I'm one of the PGY4s in Ottawa. And this experience is something that all of us as residents go to in Baffin Island. We have a clinic and an OR in Iqaluit. And as a program, we go twice a year. As residents, you go as a senior resident. And I wanted to talk about our experience here specifically. I went last June for a week, and it was a very, very good experience for a lot of reasons. So we'll kind of go over that, and at the end, I'll be happy to answer any questions that you have. Okay. So I don't have any financial disclosures. So what we're going to talk about is an introduction to Baffin Island itself, some of the geography, and then what that leads to in terms of some of the unique considerations when providing eye care in this region. Then we'll talk about the specific facilities that we have available to us at the Kekatani General Hospital, in our clinic and in our ORs. And then finally, I think it's always helpful to review what is available in Baffin Island, what are the resources that are currently present for eye care in this region, and then how we're a part of that. Because as you'll come to find out, there are actually other local supports and optometry support, for example, in the region. And I'll just discuss where ophthalmology fits into that as well. So Baffin Island is, of course, part of Nunavut in Canada. Um, the overall population of Nunavut, for the figure that I was able to find, is just under 40,000. The capital of Nunavut, Iqaluit, which is located in the southern part of Baffin Island, is here, and that's where our clinic is at the Kekatani General Hospital. However, notably, there are several, if not many, other communities throughout Baffin Island, which are included in our program. So I've listed some here, and they're also indicated on this map. And as you might be able to tell, not only is this a remote location just from the standpoint of being in the north of Canada, but even the distance from where our clinic is when we travel up north in Iqaluit is still a quite far journey for patients coming, for example, from Pond Inlet, which is the northern part of Baffin Island, and these other communities as well. And one thing that I wouldn't say I necessarily realized until going up north is that a fair portion, if not, it felt like the majority of the patients that we saw were from other parts of Baffin Island that required sometimes multi-hour flight from where they live to even reach Iqaluit. So there's another degree of a remote geography for a lot of these patients. Okay. So there are certainly several challenges to consider when caring for patients in this region. As I've already alluded to, there's just the simple fact that this is a remote region and it's quite geographically dispersed. And this lends itself to some challenges with respect to access to care. There are certain types of pathology which I will review and sort of highlight as some selected topics, which are of higher prevalence and might be a consideration earlier, or you might have a lower threshold to consider a certain diagnosis, for example, when working in this population. So just a change sometimes in the norms of what you might think about in terms of prevalence of pathology. And then finally, we have to be very judicious with our use of resources when providing care. And this comes down to all the equipment that we use and medications that we use. And I have a couple examples about this, this judicious use of resources as well. So first, we'll just talk about the remote nature of the community and access to care. So again, I've already kind of talked about Iqaluit, and I'm wondering if I actually have a laser pointer. Hang on a second. I think hopefully my arrow is visible. Is my arrow visible?
Yeah,
So
we can see it.
not so essentially, not only is Iqaluit a several-hour flight from Ottawa, but we would every day when we were there, we would have patients coming in on planes from Pang, for example. We saw many patients from Clyde River, uh, quite a fair amount of patients from Pond Inlet as well, and other communities. And, even when it's the one of two times that ophthalmology is available in Iqaluit in a year, that flight might run into issues. For example, there might be weather problems. So it's not as if we're completely ameliorating that problem by flying up north, but we definitely try our best. Um, and then there are certain pathologies that you have to, that either, I would say, either are of higher prevalence or have just unique considerations because of how they're taken care of. And I'll, I'll tell you what I mean by that. So a big one is certainly primary angle-closure glaucoma. So anatomical narrowing of the iridocorneal angle can lead to pupillary block and elevated IOP due to reduced aqueous outflow. So, certainly depending on your level of training, this is something that you're quite familiar with. So, if you look at the right-hand side of this image, this is just an example of pupillary block here, leading to elevated posterior chamber pressure and therefore bowing of the iris and closing of the angle, which can then cause either a chronic glaucoma or an acute glaucoma. And things such as hyperopia, female, short axial length, cataracts, and increased age, the lens changes just being due to the fact that the lens grows, are all risk factors for this condition. And the Inuit population, in fact, has the highest prevalence out of any population in the world of this type of pathology. So we see a lot of patients, many, many patients per day in our clinic for laser peripheral iridotomies. That definitely makes up one of the larger kind of proportions of procedures that we do, and I'll discuss all the procedures that we do. Furthermore, we definitely get calls even when we're down in Ottawa and we're covering Baffin Island, or I should say Iqaluit, on call. We get a fair amount of calls for acute angle closure glaucoma, and then we have to initiate medical management by the phone and then emergently bring the patient down for surgical management, typically in the form of laser. So certainly you need to relieve the pupillary block and promote aqueous outflow. Laser iridotomy is a very commonly done procedure for this. And then if you're familiar with something called the Eagle study, clear lens extraction, even in the setting of just anatomical narrow angles, is another available option. Although we don't have an operating microscope in Iqaluit, so certainly we're doing a lot of iridotomies. Something that you want to intervene at a prompt time, because you don't want the patient to have chronic angle closure to the point that an iridotomy is no longer effective because they've developed what's called synechial closure. And even upon relieving pupillary block, they don't have good aqueous outflow and they're so for that reason, we certainly prioritize trying to treat a lot of these patients if we can with laser preventatively as to prevent something like an acute angle closure attack or a synechial closure scenario in the future. Another condition that sees a lot of care for and requires a lot of our time up north is certainly diabetic retinopathy. So I actually found this very interesting study or paper, I should say, from Baffin Island, which just talks about, the fact that diabetes is of great burden in this community up north. There's a high prevalence, and the care for this condition can be challenging for several reasons, which is certainly multifaceted. And with diabetic retinopathy comes blinding complications. So, diabetic macular edema, proliferative diabetic retinopathy, retinal detachment. And these are all surgical problems, especially if you include an intravitreal injection. It certainly requires an ophthalmologist. So I would say that these are all surgical problems, be it either from laser or intravitreal injection or fully, vitrectomy. So not only is this something that is very common and has serious consequences, but again, just from the standpoint of resource utilization, it can be challenging because of the fact that you need certain equipment and expertise. And then another condition I wanted to mention, not necessarily due to heightened prevalence, but also just because of the nature of the treatment and how it's very difficult, is wet macular degeneration. So wet macular degeneration is when, in the setting of macular degeneration, you get choroidal neovascularization, and then exudation of fluid leading to subretinal and intraretinal fluid, which causes you to lose vision. And if left untreated, can also lead to disciform scar formation, which might lead to permanent vision loss. And neovascular macular degeneration has certainly undergone, with many other retinal conditions, has undergone a revolution in treatment in the last, say, 20 years with the advent of anti-VEGF therapy. And anti-VEGF therapy can be highly effective in treating wet macular degeneration. But the challenge with this is that you pretty much need, at least initially, monthly intravitreal injections in order to keep the fluid under control. So depending on how aggressive the disease is, these patients might have to come down to Ottawa for injections, but sometimes, just again, due to the geographic nature or the difficulty in doing that, it can sometimes be hard to meet that schedule of injections. And when we go up north, we do a lot of injections for wet macular degeneration and diabetic retinopathy. And I'll discuss a little bit what our setup there looks like, because we have a fairly unique, at least when I was there, we had a fairly unique way of assessing and treating this, just with the limited use of clinic space that we had. And speaking of which, this is actually my fridge in my apartment in Ottawa with all the Lucentis in it, which is the medication that we use. And then I flew up with this in my suitcase, and we used like all of it when we were there. So the next thing, as I just sort of alluded to, is just use of resources. The space that we work in is in the Kiktani General Hospital, located in Iqaluit. Our team is consistent of 2 senior residents, either an R4 or an R5, and then a staff ophthalmologist. And then we also have a clinic nurse and clerk as well, and OR nurses. Dr. Rama Becky has been going to Iqaluit since the late 90s. And, the Iqaluit trip with Dr. Becky is sort of this shared experience among all Ottawa residents, basically since since that time, many of whom are staff here now and have been for a while. Um, she is actually just now starting to transition out of this role. There's some other staff here, pediatrics and uveitis staff, who are starting to go up to Iqaluit, but Dr. Becky has been a fixture in the Baffin program for many years. And we all enjoy our time with her. And then so we go up, so our ophthalmology team goes up twice per year for a week. And again, we provide care to those living not only in Iqaluit, but as I was saying, it felt as if the majority were from all other areas of Baffin Island, many patients traveling in from elsewhere in Baffin Island. We do surgical care, including strabismus surgery, oculoplastic procedures like lateral tarsal strips and epiblepharon repairs, for example, minor procedures like Chalazion excisions, conjunctival biopsies. I did a couple of those, and then intravitreal injections. And then we also have a YAG laser for capsulotomies and iridotomies, and an argon laser for also the iridotomies if you need to pre-treat, which is a lot of the time, and also for laser retinopexy for retinal tears and retinal holes. This is just a picture from my room where I was staying, just kind of showing what my view was. We have 2 slit lamps and then an OCT, which is very nice. And then I mentioned the YAG and argon laser. We also have access to the main OR of the hospital, but it's not an ophthalmology OR specifically. It's used for all manners of surgery. And again, there's no operating microscope, so you're not doing any intraocular surgery in Iqaluit. It's all of the extraocular surgeries. So as I was saying earlier, the strab and the plastics, and then minor procedures. Typically, the main OR, we use that for strab pretty much exclusively, strabismus surgery. Maybe some pediatric procedures like epiblepharon repair as well that would require a general anesthetic, but everything else we just do in the clinic, like the eyelid surgeries, for example, under local anesthetic. One thing that I thought was quite, I guess a good use of our clinic space was how we handled doing injections. So basically, say for example, you're doing an injection for macular degeneration, and you're like in Ottawa, what's going to happen is the patient is going to go see a technician, get an OCT done by them, probably get dilated, and then go to your waiting room, and then you see them, and then you do your injection. But we don't necessarily have the space and the personnel for that. So basically what we did is one of the residents would be in this room. It had all of your injection supplies and medications in it and the OCT. Patient would come in, you would be sitting here, you would take their OCT, show it to them, and then they would go onto this table, and then you do the injection and then send them home. So it was like kind of all done in one room. This was also our minor procedure room. So typically, the minor procedures would be scheduled at the end of our clinic. We would see about 80 to 90 patients a day in our clinic. So it's very busy. And that's just, by virtue of the fact that there's a lot of people that need help, and, we're not there very often. So we would see, somewhere around 90 patients a day. And then at the end of the day, we would do a couple, anywhere between 1 and 3 procedures. So lateral tarsal strips, conjunctival biopsies, Chalazion excision, and drainage were all things that I did when I was there last June. And as a resident, it's a very good experience because you're given a lot of autonomy, and you're doing a lot of procedures basically all day. Like the entire day is injections and lasers, and then just seeing patients for other reasons. And then you do these other procedures at the end of the day. That was sort of our workflow. Speaking of laser, this is our laser room, and it was one laser with YAG and argon. Um, there were just even many lasers have this feature, but basically you would just like flip between either using a YAG laser or argon laser. We had a lot of capsulotomies because we do all of the cataract care in Iqaluit. The patients from Iqaluit who need cataract surgery are essentially all done by Dr. Becky in Ottawa. So then, if at some point thereafter they need a laser capsulotomy, um, maybe they'll come down for that, but typically that would just be done up north. So we did a lot of capsulotomies. We did a ton of iridotomies, and these were, what you would call difficult iridotomies. A lot of like thick iris and that sort of thing. So you learn a lot about what's called argon pre-treatment, which is where if you don't think you're going to get through their iris by just hitting it with YAG, you can use argon laser before doing the YAG laser to essentially lay down a bed and like thin out the tissue so that you can get through it with YAG. And again, speaking as a resident, it's a useful skill to have. Honestly, I do a lot of argon, maybe not a lot, but a fair amount of argon pre-treatment down here. Like if someone comes in and maybe the pilo didn't work particularly well or their iris is particularly thick, if anything, it's better to just use a little bit of argon, and then now all of a sudden you're using 5 shots of YAG instead of like 57. I find that it's very useful. And then laser retinopexy as well. Um, we we had we would did that at this laser too. So we don't have an indirect laser like with the indirect headlamp that you probably see that is the norm essentially down here. So pathology that's quite peripheral and you have to scleral depress to bring it into view, and you might not be able to see it with your PRP lens. You might not necessarily be able to get laser all the way around that. So then they would have to come down here like a peripheral tear. But basically, my rule of thumb was anything that I could see with the 90 diopter lens, I could probably laser with this setup. So then, there are certainly plenty of horseshoe tears that are in that location. And then that way they get it done there instead of having to wait and come down to Ottawa to get it done. Hang on a second. Okay. So the next thing I wanted to mention is what is the landscape of ophthalmic care like in Baffin Island beyond just the times that we go. And this is actually something that's quite important to know about, especially if you're going to be a resident here, so that you know what to recommend when you get calls from up north. So in addition to our team, there is what's called the I team, led by optometrists who provide monthly clinics in Iqaluit and also can travel to those other communities like Pond Inlet and Clyde River and so on, and go right there and do basic eye care. So they can do refraction, check the pressure, check the vision, stuff like that. That's actually very useful. Furthermore, there's one optometry office in Iqaluit. They have a visual field. So basically, a lot of our glaucoma patients, there's no visual field in our clinic, but our glaucoma patients would like get a field done at some point before we saw them, and then we'd be able to review that. And then they're just starting to do OCT imaging as well. But they're at least when I was there, they were just training their technicians on OCT. And then I mentioned also the cataract care is provided at the Ottawa Hospital in conjunction with the Ottawa Health Services Network Inc. or OSNI. And then the eye care, or sorry, the eye team can help with post-op care. So typically we do the cataract. We see in Ottawa, we see them post-op day one, give them all their drops, tell them to see the eye team in like 3 months for a refraction, basically. And then they do that, and we typically say see a nurse or family physician for an IOP check in a week, and then see the eye team later on for refraction. We provide 24/7 on-call coverage from Ottawa to Iqaluit. So during the daytime, this is integrated into one of our emergency clinics at the Riverside campus of the Ottawa Hospital. And then at the nighttime, this is covered by the senior resident on call. So the PGY4, PGY5 takes calls from Iqaluit. And that's just because you are more experienced and, better equipped to initiate immediate management over the phone, for example, when the patient is waiting for the ability to come down to see us if needed. Oftentimes, we're able to just have the patients, if they do need to come down, even if it's urgent, they can typically just take the next commercial flight down, because there's flights once a day, although I think at certain times of year, twice a day, directly between Iqaluit and Ottawa. So we would just say take the next flight down. But certainly if it's like something like a globe rupture, then we would get the medevacs down. So just as to highlight what I was saying, the eye team is crucial in providing regular ophthalmic care when we're not in town. Refractions, disease monitoring, pressure, things like that. And we get a lot of referrals from them as well. In terms of resident education, just from the standpoint of what's our experience like. So this is a picture of me last June with Jeff, who's a year above me here in Ottawa. Going up north provides a lot of unique and valuable experiences. So it's a very broad and that I took. One thing that is interesting is that when we went there, so in June, it was light out 24/7. It was always light out. So these pictures that I took were at about 10:30 p.m. These ones here. So just kind of like a view of the area. I don't think this was at 10 p.m., but yeah, that's the hospital there. This definitely was late at night when I took this picture, and there's kind of mountain or hill that overlooks the area. I think from this picture, the hospital would be somewhere over here, and just kind of the region there. In terms of future considerations. As I was saying, OCT use is one thing that they're working on. We might integrate fundus photography as well for disease screening. We already have a program in place in Ottawa for our community health centers where we are getting fundus photography done for disease screening. So we're considering getting a fundus camera up north, but probably something that would occur, if anything, after OCT. OCT is really something that allows you to zero in on blinding disease a lot of the time, if not more often than photography. But good high quality images of the posterior pole in photography can show you exudates and neovascularization and stuff like that. So another thing to think about for sure. So in conclusion, there are a lot of unique traits of this region when it comes to providing care. There is differences in the pathology that you're going to be seeing. And then there's some challenges based around the remote nature of the region. Um, the local care that is done is crucial, done by the optometrist on the eye team for routine care. And that's it. So I appreciate your attention, and I would be happy to answer any questions that you have. Thank you.
Yeah, thanks for that presentation, Dr. Denstedt. Yeah, we can open up the floor for any questions at this point, if anyone has any.
I have a question, if I may. Hi, Jim. Thanks so much. I really appreciate your sharing this story with us again. I was just wondering, I was curious if you see any potential for expanding beyond the 2 weeks per year, perhaps to other residency programs, and if there are any efforts underway to do so. I know, for example, the IVAN goes to communities up north once per year, and it's only once a year, but they have a pretty large roster of ophthalmologists from all over Ontario. So I was just wondering if you thought, if you have any ideas on how this might be expanded more, or do you think that the current barriers to resources or our time kind of prevent doing more than the 2 weeks at this time?
That's a good question. So there would be a lot of moving parts there in terms of, like, for example, the clinic that we use is used by all specialties. So it's basically like one clinic space that's shared by every specialty. So I'm not 100% sure on, like, for example, what the schedule is like, and if there would be more time available to ophthalmology. Um, that in addition to that, the OR as well. So certainly if there was more time available, then it could be something that could be done. And then after that, it would just be about funding as well, because basically the team would have to be funded for their visit. Probably something that would have to be advocated for at maybe even the federal level, to be honest with you, because it's sort of run by the federal government. You know, we see a very high volume of patients when we're there. I guess one thing that is helpful to keep in mind is that there's still regular eye care. Um, and the only thing, of course, would be some of the surgical care that is less frequent, but there's still definitely regular eye care, and patients can always come down to Ottawa as well. So we see patients from Iqaluit every day, like maybe every day, depending on the week, like at least multiple times a week, in Ottawa with like urgent problems. So we're always a phone call and a flight away from that standpoint. But yeah, I think there would probably be a little bit that would have to be sorted out from like a scheduling standpoint with other specialties, which I'm not exactly aware of how tight that schedule is. But it's a very good point to raise because of the regularity that some of these conditions require care for.
That makes sense. Thank you so much.
There's a
Yeah.
question in the chat by Izza. So it says, thanks for the great presentation. Are there any strategies that you employ for patient education and awareness about eye health?
Good question. I guess what I would say, just thinking specifically about our team, we definitely always make sure that we have interpreters when we see patients, so that, like, even when they come down to Ottawa. But beyond that, I have a feeling that much of that is probably done by the eye team, or like the regular physicians up north. The Ottawa program, yeah, to my knowledge, I'm not sure if we have like specific measures in place for like educational resources being put out. Maybe something that might be interesting to consider as a project, but probably would be best done in collaboration with the eye team, because they see the patients more often. But yeah, beyond just sort of the education that we achieve when we see them, and ensuring that we address the language barrier to the best of our ability. I don't know if we have. I could just be not aware of this, but I don't know if we like specifically have like programs in place for that.
I personally was just wondering, do you think in the future there might be, it probably has to do with funding, but potential implementation of a microscope in the area just so it's possible to do ocular surgeries?
Yeah, it's a good question. I don't know necessarily how well we'd be able to convince them, just because apart from maybe like using a microscope like a one that we're no longer using, and the reason for that is like we're able to do the cataracts, which is an elective surgery, and really like all other surgery, like all other like eye surgery, like intraocular surgery is like elective surgery. We're there twice a year. um, it's so like for example, like even if it's like, okay, this is an urgent thing like a globe rupture, better have an OR in Iqaluit. The thing about that is like we're not there, it's either like we fly there or they fly to us. um I think like it's possible that in the future that could be implemented. um but as it stands right now, like our OR is basically like filled with like strab and stuff like that. Like we still like use our OR basically like to its complete capacity. Um, yeah, the only thing I can think of that would be useful would be like if we identify something needing to be done like while we're there, and we could just do it there. But it's sort of like that's a pretty big hill to climb, like from like a cost standpoint. Um, and I have a feeling that since the resources are shared by like every surgical specialty, um, I have a feeling that there's probably some other stuff that other specialties need a little bit more. But yeah, maybe like a microscope from here might be something that could be done.
Any other questions from anyone?
I have a question.
Hey, yep.
I was wondering who covers the cost of flights when people come down? Is that out of pocket for them, or is there some sort of coverage for that?
That's covered by the federal government. Yeah. So if you need a flight for a medical reason, like that's like urgent, then it's covered by the government. But it's something to consider, when you're saying that it needs to be done. It's a pretty large expense to the taxpayer. But yeah, it's if we identify the need for an urgent flight down, it's covered by the government. It's a good question.
Thank you.
Hey, any other questions? Going once, going twice. All right, so maybe we'll end the talk there. Thank you so much, Dr. Denstedt, for taking the time to share this experience. It's very valuable to learn about this, just even in our education generally about practice in the north and some of the considerations, whether it's ophthalmological or even in other specialties as well. And I'm sure everyone else found it very helpful as well. So thanks for taking the time.
Yeah, no problem. I'm always happy to talk about this, the Baffin program and everything and how it fits into our residency program. I put my email in the chat if you have questions about our program. So great. Yeah, thanks for the opportunity. I really appreciated the ability to discuss this a little bit with you guys.
Great. Thank you. And thanks everyone for joining.
Bye, everyone.
Thank you.